Malignant vasovagal syncope in children. Malignant vasovagal syncope is a unique form of cardiac inhibitory VVS. It could be diagnosed when the patient had a VVS episode with documented cardiac arrest for more than 3 seconds simultaneously. To date, studies focused on malignant VVS in children remain limited. Whether children with malignant VVS are at higher risk of physical or mental impairment remains controversial. To deepen our understanding of this distinct type of VVS in children, this article reviews advancements in the potential pathogenesis, clinical significance, and treatment controversies of malignant VVS in pediatric patients. The most common trigger of VVS is orthostatic stress, such as prolonged standing, classified as peripheral trigger. Additionally, emotion stressors such as fear, pain, and blood phobia are central triggers that could also induce VVS. Clinical research in adults has found that malignant VVS is more prevalent in patients with central rather than peripheral triggers. The underlying pathogenesis of vasovagal syncope remains controversial. Peripheral triggered VVS is believed to be partially related to the vasovagal reflex, along with factors such as relatively insufficient blood volume and the excessive systolic status of peripheral vascular tone and neurohormonal peptides. In central triggered VVS, the afferent pathway is still unclear, though it is generally accepted that the afferent nerve transmits signals directly to the medullary vasomotor center. Malignant VVS is characterized by the significant cardiac inhibition, but the reasons why such a degree of cardiac inhibition occurs remain unclear. Just like the treatment methods of VVS, the treatment of malignant VVS includes non-pharmacological interventions and pharmacological therapies, with health education being most important. Children and their caregivers should be advised to avoid potential triggers such as prolonged standing, emotional stress, and painful stimuli. Autonomic exercise training, such as orthostatic training, is also recommended. Currently, pharmacological therapies for VVS mainly include the oral rehydration salts, beta-adrenergic receptor blocker, and alpha-adrenergic receptor agonist. However, there is a lack of control studies assessing pharmacological therapy for malignant VVS. But for malignant VVS, the alpha-adrenergic agonist may be a more suitable option. The implantation of cardiac pacemakers in treating children with malignant VVS remains controversial, and currently the recommended level of pacemaker treatment for children with malignant VVS is level 2B to 3, and the left atrial ganglion catheter ablation can improve the symptoms of adults with VVS, and long-term follow-up of malignant VVS in children has achieved good results. Thank you.